Hello, Yandong Su. Good evening from Miami.
Good evening, John.
How you doing?
Quite busy. I'm writing thesis. It's so difficult.
Oh, okay.
It's really a big project.
Yeah, we appreciate you putting it on Chinese TV. That's great.
Yeah.
That's great. Well, they love Atul there, right?
Yeah.
Because we could have them come to China for a couple, if you think it would be good. And anybody else, please tell me, okay? If you really want to see somebody, tell me. I'll try to get them.
Okay.
Whatever
Thank you,
you
John.
think that whatever you think the Chinese neurosurgery community wants to see, whoever, American, French, Brazilian, whatever.
Okay.
Okay.
Yeah.
We're all set for the next, let me show you the reservations I have already
Mm.
for the next couple of months.
Uh-huh.
Okay, let me get it. It's here somewhere. Oh, here it is.
Yeah.
Okay, let me screen share it here.
Oh.
Uh, you can see it, right?
Yeah.
So
Mm.
March 3rd is the next one. Juan Gomez Almador. He's a big
Uh-huh.
uh, he's a big endoscopist in Mexico. And
Yeah.
Mario Ganao, I believe he's a skull blaze from the UK.
Yeah.
And Victor Hugo Perez,
Uh-huh.
you know Victor. He's going to talk
Yeah.
about 3D anatomy and other new developments in neuroanatomy, which I'm sure you're up to date with.
Okay.
So that's what we got going on.
Very good.
Trying to think what we have coming up. We have
Mm.
Sema El Morsi. We have let me get it here. Where is he? Yeah, can't seem to find him.
Mm.
Okay, I'll try. I can't seem to find the
Okay.
link.
Okay.
I'll send it later. But
Yeah.
he always gets the big names. I'm sure you'll want to televise it. It's going to be good. Because I televise it, promote it, but he's the one that gets the speakers, and I don't know how he does it. He gets the best, and he has one brain day. We have 2 days. It's a weekend. One brain day and one
Mm.
spine day.
Oh, great.
Uh, no.
Yeah, Abida is here.
Oh, there you are. Okay, Noe, I see you.
Yeah, Abida is coming.
Yeah, I'll make you, you can help admit people if you want.
Hello, John. I'm here. Thank
Hey, Noe, how you doing, Noe?
Fine. I'm just getting. Just give me a minute, please.
Yeah,
So,
okay. I made you co-host, so you can let people in.
yeah,
You
thank you.
want. Okay. Noe, are you there?
Hello.
Oh, you're in the car, huh? You have your special viewing booth.
Yeah, I'm just arriving. I'm just arriving to a place. Just give me a minute. But we can start. We can work it out. I'm going to introduce to Atul, right? You
Well,
introduce me?
yeah, he can, I'm gonna introduce you,
Yeah,
and
please.
then you introduce Atul.
All right. I
Is
agree.
that okay? Are you in a good spot to do that?
Yeah, that's great idea. We can do it.
Yeah, you
You
can
can do
do it.
it.
You can do it. You've done it before.
Yeah, I've done before. Maybe we can wait for some minutes. So
Yeah,
maybe,
yeah. We're gonna wait 5, 10 minutes.
yeah,
And
so
I
people
want you
can.
to meet Yandong Su. He's a neurosurgeon.
Hello.
He did a series on neuroanatomy in the lab, and he'll be doing more webcasting in the future, but he's doing his thesis now, right? And this is no way he's from UNAM. You have a neuroanatomy background too, don't you, Noe?
Yeah, we're going to start maybe in May. We're going to start the second part of the international course of neuroanatomy. So we can invite you. It's a pleasure to meet you, Jandong.
Yeah, thank you.
Well, would you be interested in televising neuroanatomy in China? Other series of neuroanatomy, or you're not too interested in that?
Yeah.
Well, we'll talk about it later. We'll talk about it later.
Yeah, the king is coming.
Yeah, Tool is the elephant's here. You beat the elephant.
Yeah. Good morning from Mumbai. And
Okay.
morning.
Yeah. Thank you for coming. And Noe is introducing you from his car. This
we
is getting
can
fun. This is getting funky.
we can hold on for some time, John.
Yeah. We're gonna wait a few minutes. Okay. Wait for people to catch up to get in.
My dear Yang Dong is here.
Yeah, my dear professor, I'm here.
Well, Atul, now Venezuela wants you to come in Argentina.
Okay.
They're all in it. You're gonna hit all of Latin America, I think, before you head back, even though you don't leave Mumbai.
Yeah.
Virtual traveling. And Brazil wants, well, we'll talk about that later. I'll email Abby.
Mhm.
We'll talk about that later.
Let's hold on till everybody is settled. Okay.
Yeah, sure. Yandong, we're televising this in China also.
Yeah,
So, and they want you there too, Atul. Gee, I don't know what we're gonna do. We're gonna wear you out. Abby, are you in there?
Yes, John, I'm here.
Okay, good. I was worrying, Abby. When you're quiet, I get worried.
Don't worry.
That means you're getting in trouble somewhere. Mm. Let me try to find that.
Hello?
Hello, is that you, Ram?
Yeah,
Oh, let me, I want you to meet Dr. Goel.
thank you. Yes, please.
Yeah. Ram, I'd like you to meet Dr. Goel, a very prominent spine surgeon. And this is Ram. He is the manufacturer of that low-cost microscope, which we're also going to show after the webcast. We won't interrupt the king while he's broadcasting, but it's going to be after. And as you know, pharmacy and medical device companies have always supported medical education. So it should not be strange to doctors to have medical device people around. What do you think, Atul? Don't you agree?
John, I didn't hear that. Say that again.
Yeah, I think to have the medical device people as part of the scene is just the way medicine has been taught for
Yeah.
years. They support conferences, they support webinars. So that's what we're trying to do. We're trying to get support. We're not endorsing them, we're just showing them. And of course, giving disclosures and saying it's up to you to decide for yourself after due diligence. Okay, Alberto. Oh, this is great. Alberto does a lot of great series. I want you to meet him, Dr. Atul. Alberto, I'd like you to meet Dr. Goel.
Hi. How are you?
Yeah, Alberto is a neurosurgeon from Ecuador. He does a lot of televising. He's very good with Zoom and the camera and education. Okay. Oh, Harshad's here. Good. Getting a good crowd. Well, you came in from the car, huh, Noe?
No, yeah, I already changed.
Well, I like the car better.
Yeah, I have the car.
Hold on. Okay, are you ready, Atul?
Yeah, John, I'm ready.
Okay, 10, 9, 8, 7, 6. Oh, hold on. Let me make sure. Okay, speaker. Turn that off.
Yeah.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening from Miami Beach. This is Dr. John Bennett broadcasting on Neurosurgical TV. We have another webcast of the King, Atul Goel. lecturing mostly to a Spanish audience, but also he's speaking English, but most of the Spanish audience will probably understand. And let me introduce the person that's going to introduce the king is Noe Carrillo. He's a medical resident in Mexico City, and I'd like let him take it away. Greetings, Noe.
Oh, thank you very much. Thank you very much, John, for the invitation. It's a real pleasure to be with you, with all the auditorium. Thank you, Dr. Atul Goel, for being with us today. I'm going to introduce to the auditorium. So I'm going to read something about the career of Atul Goel. He's a neurosurgeon. He's graduated from the Update Medical University Physical Medicine and Rehabilitation in Mumbai, India. Actually, he's the head of the Department of Neurosurgery at the King Edward Memorial Hospital. Well, his medical interest is in spine surgery, pituitary tumor surgery, acoustic neuronoma surgery, and school-based in general. So it's a real pleasure for us to be with you. He's going to talk about the pituitary tendency and surgery and school-based. So thank you very much, Dr. Atul. You know, here in Mexico, it's a real pleasure for us, with young people, to come with you, people with experience like you. Thank you very much.
Thank you. Thank you very much. Good morning to you from Mumbai. Good morning, John. So today I'm going to talk to you. I see some of my good friends on the screen. Dr. Yang Dong from China, Harshad Parekh from Mumbai, and I'm going to talk to you today on pituitary tumors. Can you see my slide?
Yes, perfect,
yes,
perfect,
yeah, we can
perfect.
do it.
So pituitary tumors are very common tumors that any neurosurgeon will face in his career. Pituitary tumors form a part and parcel of our life. Surgery on pituitary tumors is absolutely gratifying neurosurgical operation. If you do this operation well, you give new life to the person. You completely change the person. On the other hand, if you do not do it properly, you can do big devastation, or you can create bad complication in this operation. So I will like to talk to you on pituitary tumors. Pituitary gland is located neither intracranial nor extracranial. It is a special location of the gland. This gland is located by the side of cavernous sinuses and by the side of nasopharynx, by the side of carotid arteries, and underneath the chiasma. So this special location, which is neither intracranial nor extracranial, has special function or special meaning. It is not an anatomical error, but it is a functional necessity. Relationship with the mucosa of the nasopharynx gives the pituitary gland information about what is happening outside this body. The mucosa of the nasopharynx is like air conditioner of the body. When the air goes inside the nose, the mucosa changes that temperature, and when the air reaches the trachea, the temperature is normal. When any fluid or anything that we eat or drink goes from the oral mucosa, as soon as it reaches the oral mucosa, the temperature becomes normal, and the whatever food or water or whatever goes inside the esophagus, the temperature is normal. So this is air conditioner of the body, this mucosa. It is heavily vascular structure, and this information about exterior goes to the cavernous sinus, goes to the pituitary gland, and then this master gland regulates the temperature and regulates the entire body, sitting in its special den of the sella. So sella is a very unique location, very specialized location of the pituitary gland. It is a saddle-shaped saddle, cella or saddle, and it is covered by diaphragm cell. There is a large pituitary stalk. So gland is quite a large one. It is not a small gland. And this master gland functions and regulates the entire body. So we had written some articles on this subject. One is anatomical correlates of surgery of pituitary tumors and pituitary gland. And I have written several articles on tumors when they become large or when they become giant, because they form a special subgroup, giant pituitary tumors. They become giant on quite frequently, and most of these giant tumors are non-functioning pituitary tumors. And when they become giants, they impose special challenges for a neurosurgeon. So what I'm going to talk to you today is about my work on giant pituitary tumors and my understanding of giant pituitary tumors, and the challenge that a surgeon will face whilst operating a giant pituitary tumor. So these are some of my articles that you would like to read, and there is no question that some information you can garner from these articles. So all pituitary tumors, like when you are operating on Cushing's tumor, Cushing disease, if you do these tumors properly, you not only change the face, you change the life of the person. You make the person live normal life if you remove the Cushing tumor, the microadenoma properly. On the other hand, if you do not remove it properly, these people will not survive for long. So you can give new life to these patients by removing these tumors properly. And these tumors are microadenomas. These are functioning tumors. Like acromegaly, also the tumors become a little larger in acromegaly, but in Cushing, because of the functional imposition posed by these tumors, they are diagnosed when they are microadenomas. And the information that we have got is that these tumors should be removed en masse like a nodule, and the whole tumor should be removed like a nodule, and you can remove it. And when you remove it, there is a big possibility that you completely cure the person. You give new life to these people. And the results of this surgery are extremely gratifying and beautiful. Many of these tumors become large or giant, and this is what I'm going to talk to you today. So you see some of these giants. I will show you first some of these giants. They become large, they become huge, they more often and more predominantly present with visual deficit. They are non-functioning tumors. They go into the cavernous sinus, they go here and they go there. And I want you to see some of these giants which can become really giant. You can diagnose these tumors on the basis of the way they spread. Even if they become giant or large, they are histologically not malignant or aggressive. They are histologically benign. Of course, when they are large, the recurrence rates are more frequent, but histologically benign, and they become large and huge and giant. And these kind of tumors have a big responsibility to the surgeon. If you remove them radically, you can actually, the recurrence rates may not be as high as we imagine with these giant tumors. So they can become huge and they can become large and they can go here and they can go there. So what I'm going to discuss today is there some pattern of growth of these tumors? Is there some method in the madness of this growth? And how we design our surgical strategy for these tumors, which can be difficult. And I have to tell you that if you remove these tumors radically, and if you remove them properly, you not only improve their vision, but you give them a new life. So what are the surgical nuances when we are going to operate on these kind of huge tumors, and what are the surgical subtleties that we understand regarding these tumors? So this is a huge burden on a neurosurgeon, but this burden has to be understood because there is some kind of a strategy of these tumors. There is a method of extension. There is a pattern of extension, and I am going to discuss this pattern. So these tumors can become like ferocious lions or tigers, and if we really hold them properly, we can hold these tigers and make them look like flowers. So in India, in general, we get large tumors because many of these tumors may remain undiagnosed. So this was a meningioma, and largest meningioma, the heaviest meningioma ever removed in the history of neurosurgery. This was about 1.6 kilogram weight, and this is like Mount Fuji, this meningioma on the head of this person. Pituitary tumors can become large. So the most important, and I have a feeling that a revolutionary contribution that we made on this subject about 25 years ago was when this tumor grows up or rostrally, the diaphragm goes along the tumor. So this tumor, the dura of the diaphragm goes up along the dome of the tumor in majority of cases. And the sella can become large, and the sellar dura also bulges out. So the whole tumor is actually within the confines of dura, or it is interdural in its location. So mark this word, interdural. And if you realize when the tumor goes up, the dura of the diaphragm also goes up along with the dome of the tumor. You can see that more clearly here when the tumor goes up or inside the brain, there is a covering of the diaphragm. And my feeling is complete and my feeling is absolute that if you do not know this anatomical issue, it will be absolutely difficult for you to operate on this tumor. So the dura of the diaphragm is elevated on the dome of the tumor, and the sellar dura bulges out. So there is dura which is present here and present all around the tumor, and this dura forms a beautiful plane of dissection of these tumors from the arteries of the circle of Willis and from various neurological structures which are around the tumor, like chiasma, like brainstem, like hypothalamus, and various other structures. So these tumors may look haphazard, may look like irregular, may look like infiltrating, but it is not. There is dura which covers the tumor all around. It is very rarely that the artery will be present within the confines of the tumor. The tumor is lobulated around the artery, but it is not encasing the artery. So this is the elevation of dura of the diaphragm cell. And a hugely important and previously not recognized, this concept was never recognized in the literature earlier. So this tumor, the diaphragm cell, grows along the dome of the tumor. Even when it grows in the sella, the dura covers the sellar component, the sphenoid component. There is also a thin rim of bone more often than not present on the inferior surface of the tumor. So this tumor has a pattern, has a very specific way of extension. The diaphragm covers the dome of the tumor. When it grows up, you see these kind of tumors were operated by transcranial route at a uniform, always. Means these tumors were transcranial surgery. But understanding the fact that there is dura on the dome of the tumor, there is dura here, there is no artery of circle of Willis inside. If you think that this is subarachnoid, if it is subarachnoid, then the arterial relationships will be very intimate. but it is subdural, or there is a relatively thick layer of dura which covers the dome of the tumor. You see, the whole tumor is like a ball of fire. These tumors have characteristic consistency and vascularity. They are not very firm like meningioma. They are soft and necrotic. They are vascular, but there are no specific major feeding vessels. You can remove this tumor by a special technique of debulking. So this tumor is completely, the diaphragm covers the dome. So I'm going to show you several cases where I'm going to show the anatomy of these tumors in relationship to the dura. So you see how the tumor is intracranial, but there is dura which is covering, there is dura in the cell. Even when the tumor goes up, there is dural cover. So these tumors, I call them grade 1 tumor. When they do not go into cavernous sinus, they just remain within the sella and under the diaphragm. So this tumor goes into the cavernous sinus when the tumor is around on both sides of the carotid artery, it is intracavernous. When it is only on one side of carotid artery, it is not in the cavernous sinus. So these tumors which elevate the diaphragm celli like this, which do not go into cavernous sinus, I call them grade 1 tumors. These tumors are relatively straightforward tumors, and these tumors straightforward to operate, and also the long-term outcome after radical resection is much better than grade 2 or grade 3 or grade 4 tumors. And straightforward. There is no need for transcranial operation in these cases. Even when the tumor goes up, right up till the corpus callosum, it is not involving the cavernous sinus. These are lobulations of the tumor. They are covered by the diaphragm celli. This artery is not inside the substance of the tumor. It is on the dome of the tumor. And a very thick layer of dura separates the tumor from the arteries of the circle of Willis. Even when there is a nubbin like this nubbin is also under the dura, and there is a well-defined dural separation or a plane of dissection of this dura from the adjoining brain. And we have to remember this. This is grade 1 tumor with a small nubbin under the dura. So this anatomy was never understood before of these tumors. Imagine this nubbin of the tumor which goes in the proximity of the brainstem, in proximity to the basilar artery, in proximity to the various arteries of the circle of Willis, has a well-defined dural plane of dissection. So there is dura, and this whole tumor is underneath, or it is covered by dura. I have no hesitation to say that if you do not understand this anatomy of dura, this kind of tumor is impossible to resect. And I have no hesitation to say that these tumors were always resected by transcranial surgery at least 20 years ago. You see this tumor going in the midbrain around the PCA. Dome of the tumor is in the hypothalamus. The tumor is not involving the cavernous sinus. I call these tumors grade 1 pituitary tumors. The beauty of these tumors is they are confined. They are imprisoned. They are in a jail, which is a tough, solid jail from which we have to remove this tumor. Frontal extension of this tumor was a classical indication for transcranial operation few years ago. Not few, about 20 years ago. But this part of the tumor is also under the diaphragm celli. And you can start removing this tumor, and you can get this tumor in very quick time by a transsphenoidal approach, transnasal approach, and this extension of the dura, this tumor can be resected. So these tumors can become large and huge and can have nubbin, but many of these tumors are soft, necrotic, and cystic in nature, and they are confined tumors. They can become huge. They can go beyond the corpus callosum. They can reach the convexity skull, but this dura, so that is mother dura, dura mater, or matter means mother. So mother dura will encase or engulf in both hands the tumor without letting it go outside this dural confine. So this dura and soft necrotic cystic nature makes this tumor surgery a beautiful chapter of neurosurgery. This going in the cranium, going into the sella in a confined nature under the dura. So looks haphazard, looks aggressive, looks infiltrative, but it is confined. It is benign histologically, even if it becomes huge or large or giant in size. So these kind of nubbins, these are within the dural confines. So just enjoy the beauty of these pictures, which I'm going to show you several pictures of these tumors I'm going to show you. Grade 2 tumor, what I call grade 2 is when the tumor goes into the cavernous sinus. Going into the cavernous sinus is when the artery, intracavernous carotid artery, is surrounded on both sides by the tumor. The medial wall of cavernous sinus is an anatomical enigma, and it is very difficult to understand what this medial wall is, whether it is dura, whether it is what. Some tumors enter into cavernous sinus, some tumors do not enter into cavernous sinus. My feeling is when the tumor enters into the cavernous sinus, it becomes a little bit more aggressive. And of course, for surgery, it becomes considerably difficult when it is inside the cavernous sinus. And what to do about cavernous sinus extension is a question mark, and a lot of discussion on this subject has been there, and I will discuss these issues subsequently. So this tumor is under the diaphragm, under the dura of the lateral wall of cavernous sinus. The sellar extension is under the dura. So this tumor still remains under the dura. About what is the medial wall, how it goes inside one dural compartment to another dural compartment is a little bit issue which has to be discussed. So you see this tumor is grade 2 tumor. The lateral wall is quite thick. It contains the trigeminal nerve, the third nerve, the fourth nerve. The sixth nerve is inside the cavernous sinus. The lateral wall of the cavernous sinus is stretched. The diaphragm celli is stretched, but it remains a confined tumor even when it enters into the cavernous sinus. Here it is entering into both cavernous sinuses, and I call it still grade 2. So my grading is grade 2 when it enters the cavernous sinus, grade 1 when it does not enter the cavernous sinus. You see, this tumor is predominantly going into on one side and entering into the cavernous sinus, elevating the diaphragm, elevating an extension lateral wall of cavernous sinus, which is thick. So you can understand that this tumor is a confined or a defined pattern of extension. What is medial compartment? What is medial dural wall is a question mark. So this tumor has entered into both cavernous sinuses. It is encasing both carotid arteries. The lateral dural wall is intact. The diaphragm celli is intact. And this understanding is absolutely critical. Both cavernous sinuses and diaphragm celli. So lateral wall, under the lateral wall, under the diaphragm. Both under the lateral wall, under the diaphragm celli. both cavernous sinuses in the sphenoid sinus under the diaphragm, under the lateral wall of cavernous sinus. Now, see this tumor, it has elevated the diaphragm celli, it has bulged the lateral wall of cavernous sinus. This is inside the cavernous sinus. This tumor, the diaphragm celli is stretched. The lateral wall is stretched, but it is not transgressed. So it is within the confines of the stretched dura, which keeps the tumor within confines, and these are surgical confines. Now carefully see this slide. This is grade 2 when the diaphragm celli is elevated, when the tumor is entered into the cavernous sinus. See this slide, here the diaphragm is elevated, here the dural roof of cavernous sinus is elevated. Dura of the cavernous sinus is elevated, but it is still under the dura of the cavernous sinus. This fact was never discussed earlier in the literature. This is under the diaphragm, this is lateral wall, little bit elevation of roof of cavernous sinus dura. So when it elevates the roof of cavernous sinus, I call it grade 3 pituitary tumor. This is elevation of the diaphragm, this is elevation of the roof of cavernous sinus, this is lateral wall of cavernous sinus. This is elevation of the roof of cavernous sinus, this is diaphragm cells. So this tumor has a very well-defined pattern of extension, which we described about 20 years ago. Carefully see this slide. This is elevation of the diaphragm celli, elevation of the dural roof of cavernous sinus. This is within the cavernous sinus, confined tumor. These tumors which elevate the roof of cavernous sinus are called grade 3 pituitary tumors. So if you make a cut like this here, you will see the small nubbin on this. This is part which is under the roof of cavernous sinus, dura. It is intracranial, all right, but it is under the dura, which is very important when we do surgery on these tumors. So here there is a small nubbin of diaphragm celli, and tumor is in the cavernous sinus. Carefully see this slide. Here you will find this extension of this tumor quite haphazard, quite indiscriminate. But if you carefully see this slide, there is elevation of diaphragm celli, lateral dural wall of cavernous sinus, elevation of dural roof of cavernous sinus. This extension you can see more beautifully on this picture. This is lateral dura, this is roof of cavernous sinus, this is diaphragm celli elevation. This tumor looks quite haphazard, but carefully see this slide. This is diaphragm, this is cavernous sinus, this is elevation of dural roof of cavernous sinus. This kind of a pattern of anatomy was never discussed earlier in the literature. Elevation of dural roof of cavernous sinus. This is another beautiful case. Both dural roofs are elevated, little bit elevation of diaphragm celli and elevation of dural roof of cavernous sinus. So if you make a cut like this, you will see both these tumors under the roofs of cavernous sinus. This is under the diaphragm. This is elevation of dural roof of cavernous sinus. This is elevation of dural roof of cavernous sinus. See this beautiful case you see here. This is diaphragm celli. This is inside the cavernous sinus. This is elevation of dural roof of cavernous sinus. This is elevation of dural roof of cavernous sinus, lateral wall of cavernous sinus, diaphragm celli. Both cavernous sinuses are involved. This is another very fantastic case that you will see. This is like a trifoliate extension. Now, this trifoliate looks quite haphazard, quite irregular, quite invasive, infiltrative pattern of extension. If you think that it is infiltrative, you just cannot remove this tumor by operation. It is impossible to remove this tumor if you think it is infiltrative. But if you know that this is infiltrate, it is within confines. This is dural roof of cavernous sinus, this is diaphragm celli, this is dural roof of cavernous sinus. Here also it looks quite haphazard, quite invasive, quite infiltrative, but it has got very beautiful pattern of extension, which is under the diaphragm or the dura. This is roof of cavernous sinus, diaphragm, roof of cavernous sinus, dura. So the whole thing is within the arms of the dura mother dura. This looks, you see, quite an aggressive tumor, and dangerous tumor. It is, of course, dangerous. I'm not saying it is not dangerous, but I am saying that there is a method in this danger. There is a pattern in this danger. There is a method and the madness. So this is elevation of dura of the cavernous sinus. This part is under the diaphragm. Here you can see beautifully, just carefully see the slide. This is diaphragm celli. This is elevation of dural roof of cavernous sinus, and the chiasma is compressed not by the part under the diaphragm, but by the part under the roof of cavernous sinus. And if you remove this, maybe there is some reduction in pressure, but if you want the vision to improve, you have to remove this part of the tumor. Beautiful tumor, as you can see, there is a peacock kind of head. This is the body of the peacock. This body is the lateral wall of cavernous sinus, roof of cavernous sinus, diaphragm celli, interdural location of this tumor. This is tumor with elevation of roof of cavernous sinus, elevation of diaphragm celli. Now, grade 4 or aggressive tumors, which I don't like to use aggressive word for pituitary tumors in general because they are not aggressive. They are large, but they are not malignant. They are histologically benign. And surgically also, they can be removed in a very defined fashion. Grade 4 is when the tumor encases the artery of the circle of Willis. It means it has gone in the subarachnoid spaces. It has transgressed the mother dura. It has gone beyond the dura. So this here, you see the arteries of circle of Willis, and I call these tumors as aggressive tumors. People who do not respect mother are aggressive people. Tumors which do not respect the mother dura are aggressive tumors. They are not only surgically difficult, but recurrence rates are quite high, and surgery on these tumors can be absolutely dangerous surgery. This tumor is encasing the basilar artery. Pituitary tumor, which does like this, going in the subarachnoid spaces, is grade 4 tumor. So in general, these tumors, this is grade 1 tumor. When the tumor comes in the sphenoid sinus, also there is dura, so my grading does not change. Sometimes there is quite an aggressive extension in the sphenoid sinus, but even this extension is within the confines. And if you see, majority of these tumors will have a thin bony shell in front of the tumor. There will be thinned out dura. There is erosion of the bone, not destruction, but erosion by pressure. by prolonged pressure. These are slow-growing tumors. Prolonged pressure, like in trigeminal adenomas, like in various other benign tumors, the bone is eroded. Sometimes these tumors have significant extension into the sphenoid sinus, and there is no controversy as to how to remove these tumors, because you can put your finger in the nose and you can start removing these tumors under the diaphragm, and there can be dural presence on the dome of the tumor. So these tumors can extend in various fashions, in various types, and we have to know how these tumors extend. So this is my grading system. Grade 1 is when the tumor is under the diaphragm, it does not go in the cavernous sinus. These kind of extensions are nubbins of the tumor. No matter how big it becomes, how rostrally it goes, but it remains within confines, I call it grade 1. When it goes in the cavernous sinus, one or both sides, the diaphragm is present, the lateral wall is intact, I call it grade 2 tumor when it goes in the cavernous sinus. When it elevates the roof of cavernous sinus, this elevation, I call it grade 3 tumors. It is inside the cavernous sinus. It is under the dural confines. When it goes in the subarachnoid spaces and encases the arteries of circle of Willis, I call it grade 4 tumor. And this dural classification, this understanding of diaphragm celli, I have no hesitation to say that this understanding has completely revolutionized pituitary tumor surgery. Without any hesitation and without any doubt, I can make this statement. And on the basis of this understanding of anatomy, I have written several articles, and this classification of mine, with these numbers which I had written about 15 years ago, these numbers, now my numbers of pituitary tumors is beyond 5,500 cases, and large majority of these tumors are giant tumors. You can see that most of these tumors are grade 1, a large number is grade 2, and a significant number is grade 3, and relatively minority of cases is grade 4. So let me show you some cases. So this is a large tumor. Just open the anterior wall of the cella. There is no need to remove the planum sphenoidal or tuberculum celli. There is no need to approach this tumor in this direction. Just remove the anterior wall, start breaking the tumor, debulking the tumor. These tumors are soft tumors. These tumors are vascular but soft. Even if the tumor is going right up to the corpus callosum, you can remove these tumors. No coagulation is necessary. Do not coagulate. Break the tumor, break the tumor, break the tumor, and the whole tumor will come. The diaphragm celli will bulge into your field. Unless and until you see the entire diaphragm celli, it is not the end of your operation. The diaphragm celli should be seen in a panoramic fashion, and it should bulge into your surgical field. If you have not damaged the diaphragm celli, there is not even need to put any reconstruction material. My policy of putting fat in the sphenoid sinus and in the cella is when I see CSF in my surgical field. If I do not see CSF, it means there is dura of the diaphragm which is protecting the intracranial structure. You don't have to. But majority of cases of this size, I prefer to put in the sphenoid sinus fat. These tumors can be removed in quick time, maybe in 20 minutes or 30 minutes, you can remove this tumor. And most important is these are non-functioning tumors. These are benign tumors. And immediately after surgery, patient will say, doctor, my vision has improved. I can see better. So these are surgically very gratifying tumors, very beautiful tumors to remove. So this is like uterus is like diaphragm cell. The natural course of is not cesarean section. The uterus is the most powerful muscle of the body. It pushes the baby down. Similarly, the diaphragm cell by itself has the power to push the tumor down into the surgical field. As you can see here, these are soft necrotic and cystic tumor. You break the anterior wall, debulk the tumor, debulk the tumor. This tumor I don't remember this tumor, but I can tell you this tumor will be very soft tumor, very fantastic to remove. Not more than 20 minutes you should take to remove this tumor, and the whole diaphragm will come and bulge into your surgical field, and the patient is cured instantly. Recurrence rates are very, very low in these tumors. This is very beautiful tumor to remove. Large belly, open the belly and start removing and delivering this tumor. The diaphragm will come into picture in quick time, and the patient will recover in vision as soon as the operation is finished. This kind of nubbing, there's no need to do a transcranial operation. There's no need to open the planum sphenoidal or tuberculum celli. Open the anterior wall of the cella. Start debulking the tumor, debulking the tumor, debulking the tumor, and you can beautifully remove this tumor. If the tumor goes into the sphenoid sinus in this pattern, this makes it easier to remove. You remove this, then the rest of the tumor will fall down. My strategy of removing giant tumor is first break the legs of the tumor. First remove the lateral aspect of the tumor, and the head will then bow down into the surgical field. Go first laterally, remove the lateral extension, and I use, you see, it is not important whether you use endoscope or whether you use microscope. It is your understanding of the philosophy of the tumor. For your information, I do not like to use endoscope for pituitary tumors. Open the cella widely, remove the anterior, make a cruciate incision, start debulking the tumor under direct vision. First remove with both sides laterally, break the legs, and then the head will bow down into your surgical field. This kind of tumor is, you see, there is some blood in the tumors. This is special consistency. Going into the cavernous sinus, start debulking, open, and many of the times this lateral extension is removed by virtue of the consistency of the tumor. These tumors are soft. These tumors can be sucked. You have the exposure laterally by removing the anterior wall of cavernous sinus, and if you can suck these tumors, you can suck them beautifully. You see this extension? I have to tell you, many of the people who are watching must be very young. They might not know that this kind of tumor was always removed transcranial operation, but understanding that dura is intact, open the anterior wall, no need to open the tuberculum cell, no need to see the CSF during surgery. If you go in this direction, you will open the CSF spaces. But no problem in opening there, but then you have to reconstruct and all those things. But you can avoid, just come anterior wall. This is interdural. This is not subarachnoid. This is special basal dura, which is outside the confines of CSF spaces, outside the brain. If you remain in this space, it is outside the skull. It is extracranial. Actually, this is extracranial tumor. The CSF space, the subarachnoid space, the brain is inside, not. This is patient with large belly. You first open the belly and then the head will bow down in quick time. The surgical result will be fantastic and quick. My feeling is there is no beautiful surgery, no gratifying surgery like this, because the patient recovers in the most important function of vision as soon as he comes out of anesthesia. So this tumor, first open this part, the inferior part, remove the tumor, remove the tumor. You see there are soft areas. This is not difficult tumor. There is no need to go transcranial. The question is endoscope useful? may be useful for some tumors which are going laterally into cavernous sinus, but in general, my personal experience with more than 5,500 cases is that it is not necessary. It may not be absolutely necessary to use that, but if you are using it, is not a problem. Endoscopes are more useful for tumors like chordomas and other tumors, but not for pituitary tumors. Now you see this tumor I had done in 1998, about so many years ago, more than 26 or 27 years ago. Just removed the anterior wall of the sella, and I had removed this huge tumor, which at that time in 1998 was almost uniformly removed transcranial. But understanding in 1998, you see how beautifully the tumor has been removed. This was removed in year 2000 by transnasal approach. This tumor is also looks like, but it is under the diaphragm, this nubbin of diaphragm. This tumor, just anterior wall, break the tumor, cavernous sinus is not involved. This is another tumor. I will say these are very straightforward tumors if your anatomy of diaphragm is clear. This kind of head of the tumor will certainly come down. Big belly of the tumor, break first the legs of the tumor, and this will come down in the surgical field. How you bring the tumor down into the surgical field, how you get it debulked, and how you break the tumor forms the basis of pituitary tumor surgery. If you keep on coagulating, I have never used coagulation or cautery inside the tumor in this tumor ever in pituitary tumor surgery. There is no need to coagulate. There are no vessels in this tumor. It will bleed, but you remove the tumor and you put Surgicel or gel foam, the bleeding will instantly stop. This is a nubbin here. This is under the dura. This is immediate postoperative period. This is immediate postoperative, but this will fall down in 3 months or 2 months. You will find nothing here. This looks like similar picture like this, but this is immediate postoperative. This is very beautiful tumor to remove. I have no hesitation to say that these large giant pituitary tumors form the most fantastic chapter of neurosurgery, one of the most gratifying neurosurgical operation that you will ever see. So open the sellar dura, remove the tumor, and when to do packing, when not to do packing. I have already said that my classification of doing fat packing in the sella is when I see during surgery, CSF in my surgical field, break the tumor, I do not open the planum spinodale or tuberculum celli, and learning the art of breaking the tumor forms the basis of surgical resection. This tumor, you see how it is going into the hypothalamus towards the brainstem, but there is dura which covers, and dura protects, and dura forms a beautiful plane of dissection for surgery. This is another giant tumor which is certainly dangerous. This is the giant tumor going in this direction, but you can imagine this is quite necrotic and cystic and soft tumor. And this is immediate post-op, some blood here, but this will gradually disappear. Diaphragm will gradually come down into the surgical field, not later, but quickly. This is another diaphragm. This is post-operative. This is another one. This is immediate post-operative. This is another huge one. These vessels are not arteries of the circle of Willis. If they are arteries of circle of Willis, you cannot remove this tumor. This is large venous plexuses in the tumor. This tumor I had done in the year 2001, about 23 years ago. Quite a large tumor, as you can imagine. There was a small nubbin which was, I could not get this tumor down, so this tumor was left behind. There is a recurrence in this tumor in 2007. And I don't remember what I did. Maybe I reoperated, but my learning from this tumor is when it goes when there is a residue in this tumor, even then you can actually conserve, you may avoid radiation treatment, but in these massive tumors, which are more than 6 centimeters, and there is residue, I like to now give radiation for these tumors. This is another tumor I had done in the year 2001. You see, just anterior wall of the cella removed, and the whole tumor has been removed. This is immediate postoperative scan. This patient disappeared. You see this, how it is going into the frontal brain, and the whole thing was removed beautifully. In 2008, there is a recurrence. So now if the tumor, my philosophy is still not very crystal clear, but if the tumor is more than 6 centimeter, even if I have removed it completely, I have a feeling that we should give radiation to these tumors. So this is another very fantastic tumor, as you can imagine, and this is post-operative. This is another very dangerous looking tumor, and this is post-operative image. There is some residue here, some residue there. But as I have mentioned, these tumors are benign, histological. More important is to relieve the pressure on the chiasma. If some tumor remains in the cavernous sinus, these non-functioning tumor, it is not a huge problem. On the other hand, if you enter into cavernous sinus and you damage the sixth nerve or you damage the nerves of the cavernous sinus, you can create big ophthalmic eye movement disturbance. So whether to enter into cavernous sinus in grade 2 tumors is a question mark. But in functioning tumors, that question mark does not remain a question mark. If you want to improve the tumor in a functioning tumor, you have to enter and remove the tumor within the cavernous sinus. So this is the tumor which has been resected. So this tumor, there is some tumor in both cavernous sinuses which is present in this case, but this is a non-functioning tumor. I'm not sure if I will give radiation to these tumors. Maybe I just observe, and the vision will improve dramatically and quickly. The tumor which extends like this into the cavernous sinus, but you see there is a softness, there is a beauty in these tumors, and you can remove this tumor, but if there is some residue here and there, you can either observe or give radiation. Inside the cavernous sinus, some residue here. So I'm showing you several cases just to show you how to handle these cases on the basis of anatomical concept. This is elevation of the roof of cavernous sinus, elevation of the diaphragm celli, and you can enter into the cavernous sinus. The third nerve is very intimately related into this part of the tumor, and you have to just use your gentle suction. If you use sharp dissection in this area, it might just be a little bit dangerous. Now, this nubbin is not under the roof of cavernous sinus. This nubbin was left behind. This is immediate postoperative. I do not know how much was left behind or not left behind. But you can go from the sphenoid sinus, big legs, big belly, remove the tumor, go inside, and you can get the diaphragm completely into picture. And that requires experience. That requires how you remove the tumor, how you handle these tumors. You see, this is tumor elevation of diaphragm celli, elevation of roof of cavernous sinus. This part in the roof of cavernous sinus was not removed. This is another tumor, some residue here, but huge part of this tumor has been removed. The chiasma is quite clean and the tumor in both cavernous sinuses has not been removed in this case. I had done about 2001, so several years ago, I had removed this tumor. Now you see this problem, grade 3 tumor. This part of the tumor is under the roof of cavernous sinus, diaphragm celli, lateral wall of cavernous sinus. This part has been removed. This part in the roof of cavernous sinus has been left behind, grade 3 tumor. Now, whether to give radiation or not is a question mark. Grade 3 tumors, in my understanding, are more aggressive tumors. And now I am erring in favor of giving radiation when there is in grade 3 tumor, there is this kind of residue. This I had operated 20 years ago. There is elevation of roof of cavernous sinus, elevation under the diaphragm. This part of the tumor, grade 3 tumor, was left behind. I had not given radiation. You see, in 2009, this tumor has grown. So now my strategy for grade 3 tumor is that if there is a residue, I probably prefer giving radiation. This is another tumor, both elevation of the roof of cavernous sinuses on both sides, diaphragm. There is some residue in the cavernous sinus. This tumor also I had operated some 20 years ago, elevation of roof of cavernous sinus in the oculomotor region, in cranial nerve, in the oculomotor system, but there is beautiful plane of dissection formed by the dura. Elevation of diaphragm. You see, this is postoperative air in the cavernous sinus under the roof of cavernous. So you enter like this. Use your suction. Do not use sharp dissection. Use the consistency of the tumor and remove the tumor. You see, elevation of roof. This part of the tumor has been, this is immediate post-op. Some may be blurred here. And I don't think there is any residue, some blood, but this is the way this tumor was removed. This is another beautiful case. Long time ago, I operated some residue in the cavernous sinus. As you have seen, that all the cases I have shown are by transnasal route. I am saying all these pituitary tumors can be removed by transnasal route. You see this tumor, lateral wall is intact, elevation of roof, elevation of diaphragm, some residue here. Predominant into cavernous sinus, I had removed this by transcranial route. Residue in the cavernous sinus, what to do, what not to do is an issue. Residue in the cavernous sinus is an issue. Whether to remove or whether not to remove, here there is residue in the cavernous sinus, question mark. But patient, if he improves. But as I have mentioned to you, when there is dual tumor under the roof of cavernous sinus, nowadays I prefer to give radiation. Large pituitary tumors should be removed radically. If there is a residue in the tumor resection, this residue can sometimes lead to fatal postoperative pituitary apoplexy, a fact which I had described about 30 years ago in this article. For the first time, this concept of fatal postoperative pituitary apoplexy. This is another beautiful tumor. As you can imagine, both roofs of cavernous sinus are elevated. The tumor in the both roof is left behind. Rest of the tumor is removed. And this patient I have been following for several years. Both these tumors have not grown. I had not given radiation at that time, but I think this patient did deserve radiation treatment. So these tumors, all these tumors can be removed by transnasal route. Grade 4 tumors remains an enigma. Grade 4 tumors are dangerous. They are like cobras. If you remove this tumor by transnasal route, you can create huge complication following surgery. Huge means these tumors there can be a devastation. Whether these tumors should be removed transcranial route or whether they should be removed transnasal route, how you have to preserve the perforators of the anterior cerebral artery, near the ACOM, near the perforators of the trunk of the artery, is a dangerous issue. But what we have recently realized is when the tumor goes beyond the diaphragm celli, they are usually hormonally active. Even if the prolactin level or other hormonal levels have not gone up too much, many of these tumors can be and should be treated by cabergoline or by antiprolactin drugs. So these tumors, in my estimation, which encase the artery of circle of Willis, are aggressive or malignant pituitary tumors, and these tumors form a different chapter. They are still histologically benign, but surgically dangerous. So when you see a tumor like this, you just better be very careful. In this tumor, I still feel that radical resection may not be the option. Radical resection may not be possible, and radical resection may indeed be very highly dangerous. You can remove some of these tumors beautifully like this and showcase the work. Now, this patient, if you see here, prolactin is very high in this tumor, and this tumor was treated by drugs, and how this tumor got resolved by drugs without any surgery. So these tumors, which are grade 4 tumors, should be treated and should be assessed for drugs. My current feeling is these grade 4 tumors can be treated. You see, this prolactin level is 18,000, and this is after treatment of drugs and how the tumor has resolved without any surgery. So in large giant tumors, my danger issues are when the tumor is very, very big, of course, that is a danger. When it is grade 3 or grade 4, of course, 4 is a different beast completely. It is a different tumor. Grade 1 is a simpler tumor. Grade 2 is a little bit more difficult tumor. Grade 3 is a different tumor. Higher grade tumor is more dangerous. When the patient is drowsy, it makes it very dangerous tumor. When the patient comes with altered behavior and altered consciousness, drowsy state, unconscious state, these are dangerous tumors. When the patient presents with hypothalamic disturbance, it is another danger signal for you. So my indications for radiation treatment are still not very convincingly I have put forth, but in grade 4 tumors, radiation is certainly required. Grade 3 tumors, when it is some part of the tumor is left under the dura of the roof of cavernous sinus. Grade 1 tumor, when it is more than 5 centimeter, and recurrence, little bit controversial. We have studied proteomics in my department of these tumors, and these gradation of these tumors will change according to the proteomics. I don't want to go into the details. Now, rapidly, I want to show you some tumors with cyst. Pituitary tumors sometimes have a cyst, not sometimes, very frequently, of different kind. And I want to show you some beautiful fluid level in the pituitary tumor. You see, fluid level, I want to show you. And these tumors can be like some schwannomas where there is a fluid level. So this was my article published in 2010, 15 years ago, about fluid. I want to rapidly show you some pictures. Just see, there is a fluid level in this tumor. There is 2 fluid levels in this tumor. This is a large tumor. If you carefully see this slide, all these cysts have fluid levels. There is a fluid level. Part in the cavernous sinus also has a fluid level. There is a fluid level here, fluid level here. There is a fluid level. This tumor has multiple fluid levels. You see, fluid level. Patient will be supine, the level will be. There is a fluid level in this tumor. There is a beautiful fluid level in this tumor. There is a fluid level in the part of cavernous sinus, and there is a fluid level here. There is a fluid level here. There is a fluid level here. There is fluid level. Now, what is the significance of this fluid level? There is fluid level. All these cysts, multiple cyst necrosis have fluid levels. Multiple cysts has multiple fluid levels in the tumor. The significance of this fluid level is that these tumors are relatively easier to resolve. They contain some liquefied blood. As soon as you make an incision, the blood comes and the whole field relaxes, and this is a relatively quite straightforward operation. And along the wall of the tumor, there is some reddish tumor which you have to remove. The problem in this tumor is they are easier to remove, but the recurrence rates in these tumor is much higher than when there is in solid tumors. Fluid level. And the other issue is when these tumors recur, they recur with a fluid level. The recurrence also has a fluid level. You see, there is a beautiful fluid level. There is a beautiful fluid level in this tumor. Multiple cysts with all these tumors with fluid. You see fluid level. The tumor is huge going here, but there is a fluid level, relatively simpler, looks difficult, looks dangerous. Going in the roof of cavernous sinus looks difficult, but there is a, tell you, very straightforward tumor to remove. And these fluid levels, this is the tumor which was removed and it recurred with a fluid level. So these are fluid levels, my dear friends. Thank you very much. I hope you enjoyed this presentation. You enjoyed watching these multiple pictures of pituitary tumors, and maybe your next pituitary tumor surgery you will do with a different perspective, with a different format. Thank you very much, my dear friends.
Very good, Atul. Noe? Are you there, Noe? Okay. Well, thank you very much, Atul. Excellent. I'm not a neurosurgeon, but Noe, are you there? Perhaps he stepped away.
Okay.
Oh, okay, Yandong, can you moderate, please?
Yes, yes, I can moderate. So
Getting first into service, late.
it's a very, very, very beautiful lecture. You know, the key point to I summarize the key point for Professor Atul's lecture. The key point is to respect the dual matter of brain. And I have read this paper several times, and every time I read this paper, I have new idea, and I recommend everybody go back to Professor Atul's lab surgery in last September. You will see why we do not need the bipolar coagulation during the transnasal pituitary tumor resection. And I hope everybody enjoyed this lecture. Is there any question?
Okay.
Harshad is there, John?
Yeah, Harshad, you know, I think Harshad just stepped away.
No, he's
Hi,
there.
Hi, John, I'm awake, very much
Oh,
awake.
hey, you're back, you're back.
I'm-
Okay.
I'm here. The king is there, so I can't sleep. He has given a wonderful talk as usual. And there's a new words which he has given, break the legs and open the belly of the tumor. And you are in, this is something new which we have learned today. Otherwise, he always demolishes the tumor. Yeah. And, Atul, just one quick question, whether would you like to go for extensive removal in grade 3, your grade 3 type of tumor, or just leave it in the cavernous sinus?
See, Harshad, that is very important. Actually, grade 3 tumors are more aggressive, as I have mentioned, in their behavior. And sometimes to go into cavernous sinus and remove this tumor becomes quite straightforward if the tumor is soft. You can just you go laterally, use your suction, and you can get this tumor. In non-functioning tumors, there is actually no need to go there, because the third nerve becomes quite in danger when you remove the part which is going in the region of oculomotor cistern. And the third nerve, can come in a little bit of a danger. So If it is easily possible, do it. If it is not possible, you can avoid it. That is my answer.
And for a residual tumor, you always radiate?
Now, that is another issue which I am still not very convinced about, but in grade 3 tumors, I think these patients, the recurrence rates become quite high and you need to radiate these tumors. My feeling is, but I'm not yet convinced.
In acromegaly, I've seen many times the tumor remains in the cavernous sinus and they come back.
Yes, in acromegaly, in functioning tumors, Harshad, it is a different story. When it is functioning tumor, you have to try to go into cavernous sinus and remove the part in cavernous sinus, because in functioning tumors, particularly in acromegaly, if you don't remove, you can have persistent acromegaly, and there are no real drugs for acromegaly. Like for prolactinoma, there are drugs here and there. But for acromegaly, there are no drugs. And when it is Cushing disease and tumor goes into cavernous sinus, it is a bad news for the patient. The part is, even if you remove these tumors become, they are a little bit more aggressive form of tumor, and the outcome may not be as pleasant in these cases. And then you have to give radiation and other things. But in general, these are bad tumors, as you know, Harshad.
Yes, I agree with you. Fully agree with you. Thank you. Nice lecture. Wonderful.
Thank you, Harshad.
I think you must be the first one who has crossed 5,500 cases in Pituitary. So many cases. Wonderful. Great.
Okay, more questions, comments on anybody? Okay, Harshad, excuse me, thanks for coming, Harshad, and thanks, Yandong, for coming.
Thanks, John.
And
Thanks, John.
Atul, of course, thank you for another lecture. Next up on the slate, we're going to work it out. It's either Brazil, Venezuela, or Argentina. Take your pick. We don't know which one, but we'll let you know.
Thank you, my dear John.
Thank you.
This is my pleasure and this is my opportunity. As I mentioned to you, last time during COVID times, people were in their houses, studied in their rooms, and they were listening to webinars. So when I went to Colombia, from small little countries, many of the names of the countries I had not even heard, and they had heard these lectures on webinar. So this is a huge educational opportunity for people who hear and for the people who give these lectures. And as you know, that this is widely infiltrated into the Neurosurgical Society. Whether you are from a rich country or whether you are from a poor country, you just need your internet and you can see all kinds of educational things which are going on in the world. You don't need to travel here, travel there. And I have enjoyed this medium of education through the years, through your channel in particular, as you know. And what your contribution, Dr. Yangdong, you will agree that John Bennett's contribution in education is absolute. What I do is all right, but what he has given this medium of neurosurgical TV to the whole world. Harshad?
Harsha lit. Harsha lit.
Thank you very much, Atul. But really, it's Zoom. Zoom is the star of this webcast, because without this platform, it's just a tremendous platform. And we're trying to make it work, Atul. As you know, in the past, medical companies, medical device companies support medical education. And we're trying to change that for us so we can pay for expenses, promotions, etc. So we're allowing medical device companies to present their equipment after the webinar, which we're going to do now. We have Ram Kumar from Sanmar. He has a low-cost neurosurgical microscope, which, as you know, Atul, it helps to operate, to have a good microscope, obviously. So I'd like to introduce Ram. Ram, are you there? Hello, Ram. You're muted.
Hi, hello. Hi, good morning to everyone.
Okay, the floor is
Dr. Atul,
yours.
sir. How are you, sir?
The floor is yours.
Yeah. Shall I just share the presentation, the product
Sure.
details?
Sure.
Yeah. So, hello, everyone, and I am Ramkumar from Sanma Medines, manufacturing a surgical operating microscope for all microsurgical disciplinaries. So here I would like to just share some brief points about our neurosurgical microscopes. The brand name is, sorry, the model name is Ocula. So what actually we make is we make surgical operating microscopes, 3D exoscope, and very recently we developed a robotic assisted endoscope pump. It's still some testing for some regulatory process. So we are planning to launch very soon. So these are all the product range in our company where manufacturing is. And we are the only Asian and third global brand making surgical operating microscopes for all microsurgical procedures. And very fortunate to have that fourth global brand to make microscopes for neurospinal plastic reconstructive. So this is our features of the microscopes with 0 to 210-degree tiltable binocular. And this is our integrated angulated eyepiece extender, so that it comes with a little bit 30-degree extended for the surgeons, where they can escape from their next strain when they do with the long surgical procedures. And we give an option of a 200 to 500 working distance. And here I would like to add one point. We are working on for the optics range from 200 to 1000 mm working distance. So we are, I think we'll be launching very soon that working distance also. And these are all our other features like electromagnetic brakes, and we have a joystick powered control for optical swivel, for axial and swivel positioning, and with the X-ray movements. So optionally, we give with all the controls with foot switch options also. And this is what I mentioned, the 30-degree inclined angulated extender for eyepiece, so that the surgeon can stand in a comfort position for a long surgical procedures. So these are lateral and cooperative options. And these are joystick controlled for a zoom, focus, illumination intensity, and a joystick control with hand grips, and for an electromagnetic brake controls. And as well as the same thing within a foot switch control also, we are offering the same things. And we give optional ICG filters, yellow 560 or IR 800. And this is our imaging system options. We offer full HD or 4K with a live recording solution and still image storage, and the storage capacity for 1 TB or 4 TB as a choice. And again, monitor as a choice, because there is 24, 27 inch, 32 inch. It depends upon the requirement. So we provide all this type of options of monitors, either regular grade or medical grade. So thank you for the opportunity, Dr. John and Dr. Atul and all the other delegates. Thank you for the opportunity.
Okay, thank you very much. Atul, do you have any comments?
No, this if we can have a low cost microscope, and if we can disseminate such microscope in people who cannot afford high power, high expensive microscope, a good service to the neurosurgical community, I think we must encourage such microscopes, maybe for surgery, also for dissection purposes, during lab purposes. If we can have this high power microscope during operation, if we can have this good imaging, good maneuverability, and possibility of good lighting, I think we may encourage such beautiful endeavors, John.
Mm-hmm. So what are the things a neurosurgeon looks for in a microscope? Well, I'm not a neurosurgeon. I've never even used a microscope. But what do you look for essentially in a good microscope?
Like for Zoom, when you're using Zoom, you want good voice, good picture. For
Okay.
microscope, when we are using microscope, one is we want to see it properly. We want to see the structures very clearly and properly and brightly with proper light in the corners, in nook and corners of the surgical field. That
Okay.
is one. Second thing is when the surgeon sits comfortably on his chair, he should not be uncomfortable. He should be sitting in a comfortable position and should be able to maneuver the microscope in all the direction easily and quickly. So he should be able to bring it down, turn it in one corner, turn the microscope with just touch of button, and then you should be able to turn it quickly and precisely. The magnification should be there. The zooming capacity of the microscope should be there. It should be quick and fast. And of course, then you have to integrate this with a good camera and good picture for recording purposes. It should be relayed on a high, big TV kind of relay, which was shown here by in this microscope that Mr. Ram was showing. And then you go further, like you have to integrate with navigation system, integrate with various dyes and all those things, ICG compatible. That is next version. Ram, is your compatible with navigation system, your microscope?
So, Doctor, we are working with one company for a navigation compatible, Doctor. So we are working on that, Doctor. Very soon we'll be launching that feature.
I think it is not such a greatly important feature. I will say
Yes,
it is
sir, yes,
more of a cosmetic kind of situation where you are integrating with navigation and all. I had microscope which was integrated with my navigation in my department for 15 years. I never used that navigation integration. ICG compatible, like intraoperative dye monitoring and all, can be useful, and I think that is a thing that you must go for. Navigation compatibility, I don't think you should waste your time on that. Rather, you make it more compatible, more easy maneuverability, up and down, sideways movements, forward movements, zooming, quick zooming, high intensity light. Those features are more important than wasting time on navigation.
Atul, have you ever helped design a microscope or had to give input to someone that's designing one?
They sometimes keep on asking here and there, but whether they use that input, I'm not sure. But I have worked with various, companies who supply microscope, and I have worked with high-end microscopes all throughout my career. And even when I was working in a public hospital, which is charitable free hospital, I had the luxury of using high-end microscope. But high-end, I am sure with time, this microscope, which has been shown, can deliver what any neurosurgeon will like to have. I think I can only wish them well, and I hope they can promote this beautifully and go further in the business of microscope. This is a very, very important tool for neurosurgeons. And in nook and corner, in small towns, in villages, wherever there is any kind of neurosurgery, any kind of spine surgery for that matter, this surgery, microscopes are mandatory tools. And I have no hesitation to say that if you give the product, there are buyers. Depends on how well you do your, how good your equipment is.
Okay, very good. We appreciate your input. And thank you, Ram and Yandong, and thanks everyone else for coming. And we'll let you know where Atul's going to be next in South America. Thanks, everybody.
Thank you. And